So we continue to talk about the complications of prematurity. So as we discussed in the last video, that a child, preterm born child with respiratory distress, low blood pressure, and we've seen the X-ray findings of that child with grunting, nasal flaring, all that symptoms. When we see that in the chest X-ray the lung volume is small, that is the lung is not expanding properly, so there is small lung volume, air in the bronchial tree, that is a air bronchogram, that is what is conspicuously clearly visible because the lung anyways is not inflating completely. Then there is fine reticular granularity in the parenchyma. So you will see the lung parenchyma shows white dots. That is also because the lung has not expanded completely. Now this picture can also be referred to as ground glass appearance or a salt and pepper appearance. Okay, some of the texts they also describe this fine reticular granularity as salt pepper appearance. So this is easy to remember. Now when we talk about the treatment of a child with respiratory distress syndrome, this preterm newborn needs NICU care, that is neonatal intensive care unit care is very important because oxygen is the mainstay of treatment of this condition, because most of the things that are happening here is because of poor lung expansion leading to hypoxia. So oxygen is the treatment that is to be given to the child, but it's extremely important to give it in the right dose, in the right way, because if you give excess of oxygen, it can lead to a lot of problems like bronchopulmonary dysplasia. We'll discuss it in the next video. Periventricular leukemia, retinopathy of prematurity, and necrotizing enterocolitis. These are the complications which can happen if you give a lot of oxygen while treatment. Then we have now what is it which happens when there is oxygen that is given to the child? There is we know once there is oxygen in the system, there is dilation of the vascular bed that leads to a left to right shunt. Now we know when the pulmonary vascular bed dilates, the outflow for the pulmonary artery now gets easier, dilated. So definitely the pressure in the right ventricle lowers, and so there is a left to right shunt. Now after this, when there is dilatation in the pulmonary vasculature, there is leakage of proteinaceous substances into the alveoli and the terminal bronchiole. So proteinaceous fluid tends to get into the alveoli and the terminal bronchiole. There is also sloughing of the alveolar cells, because we know that there was hypoxia that has led to ischemia of these cells. So after this oxygen therapy is started, there is sloughing of the cells and proteinaceous fluid exudation into the alveoli and terminal bronchiole. Now this proteinaceous fluid plus cellular debris is what forms the hyaline membrane that was depicted when these children, those who did not survive, underwent an autopsy and an H&E staining was done. It showed to have a picture like hyaline cartilage. That is, the color on H&E staining is amorphous and eosinophilic, and that is the reason, since it resembles the hyaline cartilage, this disease is known as hyaline membrane disease. Okay. Next we come to the treatment modalities, that is the way by which we can give oxygen to these children. So we know something very commonly anywhere, be it a NICU, be it an adult ICU, ventilation, putting the patient on a ventilator is definitely a very important part of treatment of children with hypoxia in these scenarios. But we have other modalities as well with lesser complication and quite comparable efficacy, which we'll discuss as effective ways of fighting hypoxia in children, premature children with hyaline membrane disease. Now, the first and foremost most important modality I would want to talk about is a Cpap, continuous positive pressure ventilation. Now, what we do in a Cpap is a continuous positive pressure which is given into the infant that keeps the alveoli open. Now, these alveoli, they are open, but the child is not mechanically ventilated. So, the benefits of Cpap are, that is, there is decreased need for mechanical ventilation in children who improve with Cpap itself. So, you needn't put the child on a mechanical ventilation. Mechanical ventilation has a lot of complications attached to it, like there is barotrauma, there is volutrauma, there is hyperoxia that leads to reactive oxygen species which causes inflammation, and definitely mechanical ventilation is associated with ICU infections. So, these problems can be fought if we can put the child on a Cpap, and subsequently we can give selective surfactant into the child, and many a times this is found to be a very good alternative to mechanical ventilation in children with hyaline membrane disease who are symptomatic. So, Cpap prevents the collapse of the unstable alveoli. The moment you put the alveoli on a continuous positive pressure, they tend to open up. You can put in surfactant. There are various ways of putting surfactant, we will discuss about it, but the mainstay is what I am trying to impress upon, that Cpap with surfactant is a very good option for treating infants with respiratory distress syndrome. Now, apart from Cpap and subsequent selective surfactant, definitely we have, and one more benefit of using a Cpap is there is decreased bronchopulmonary dysplasia as well as decreased deaths associated with this in the first 72 hours. So, it is a very good alternative for the delivery of oxygen. Next, we have mechanical ventilation. As I said, there are so many complications. I will share this picture along with the video so that it is easy for you to follow when you are, if you have issues seeing the board with the video. So, basically mechanical ventilation is associated with trauma because of pressure, because of volume. So, barotrauma, volutrauma, hyperoxia associated inflammation due to reactive oxygen species, infection associated with ventilator. Now, these problems, they lead to alveolar and pulmonary development disruption, which leads to again hypoxia and increased CO2 levels, and thus ending up into a chronic lung disease. This is something we would never want out of treatment, but because of the the effects of mechanical ventilation, the problems associated with mechanical ventilation, these problems, it kind of becomes a double-edged sword. So, chronic lung disease is something we do not want, and that is the reason, again, if there is a possibility, Cpap with subsequent selective surfactant is a very good option. Now, apart from these two mainstay of treatment, there are few more things that can be used. High frequency oscillatory ventilation. This is another alternative which is not tend to be superior to the mechanical ventilation. So, it is not very popular, but it can be used. Now, administration of glucocorticoids routinely for neonates which are on ventilators is not recommended. So, ACOG recommends against it. You have not to put the child on glucocorticoid if the child is on ventilator. This has been found to impair school performance, motor and cognitive function in the preterm neonate. So, this has now the use of glucocorticoids now has been kind of stopped. Then delivery of corticosteroids and surfactant intratracheally is being considered in some trials. So, this is again to avoid the systemic side effects of the glucocorticoids. Intratracheal delivery is under trial purposes. Inhaled nitrous oxide there is no data to support inhaled nitrous oxide, so the use is not popular now. Caffeine is something which is now very routinely used. It is available as drops, can be given IV in symptomatic children. So, caffeine use is recommended in preterm neonates, especially those weighing less than 1250 grams as per the value given in standard textbooks. Caffeine is extremely recommended these days by ACOG. Then we have vitamin A. It decreases bronchopulmonary dysplasia. So, definitely its use is very, very good. It can be used especially in very low birth weight babies, babies weighing less than 1500 grams, but due to production and shortage of production, the use has not become very popular. There is limited use, though it is found to be very, very effective in reducing bronchopulmonary dysplasia. Now, we come to the standard therapy for newborn with RDS, that is surfactant. Now, it can be used as prophylaxis or rescue. Prophylaxis, like for those neonates which are preterm and they are still not in RDS, you are expecting the child might go into RDS. So, that is a prophylaxis surfactant usage, and rescue is for those that are symptomatic RDS neonates. Prophylactic surfactant nowadays is not something very popular. The ones that we are using is rescue therapy, that is for symptomatic RDS infants. The main reason behind this is we are giving antenatal steroids to preterms. We all know antenatal before delivery 2 doses, that 1 course of betamethasone. It is very, very helpful to prevent RDS. So, nowadays surfactant prophylaxis has not much role, but rescue therapy definitely is very, very effective. Now, biological and synthetic 2 forms of surfactants are available. The biological one is the ones which is preferred because it is higher in quality and has exactly the, since it is from the animal source, so it works better. It is available in bovine, in calf form and in porcine form. All of it can be used. It is a little more expensive than the synthetic one, but it tends to work better. There are names to it. Cervanta is for the bovine, Infasurf is for the calf, and Curosurf is for the porcine variant. It is given through an ET tube. Put the ET tube and it is through it that you give the surfactant, but there are other options, other less invasive options through which you can give the surfactant, like suppose if the infant is spontaneously breathing, you can give it into the pharynx, you can nebulize with surfactant, you can give it via a laryngeal mask airway, that is LMA, you can give it through a thin catheter if the baby is on a Cpap. So, these are very, very good because you do not need an ET tube insertion. So, it reduces the complications associated with the ET tube, and thin catheter with Cpap, again we know Cpap is preferred over mechanical ventilation to reduce bronchopulmonary dysplasia or the chronic lung disease. So, these are available options to deliver the surfactant into the lungs. So, very, very important surfactant. It is the standard therapy for newborns with RDS. It reduces mortality and it improves the short term outcome for babies with RDS. Okay. So, it reduces the need for mechanical ventilation, very, 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 very effective treatment for RDS. Apart from that, antenatal steroids in 24 to 34 weeks is the standard treatment, and even at 23 weeks if delivery is imminent within 7 days. So you can give even at 34 to 36 weeks if the baby is expected to deliver. ACOG now recommends giving a single dose of steroid to the antenatal mother even in the 34 to 36 weeks gestation. And amniocentesis again does not have a role nowadays in the assessment of lung maturity when preterm delivery is imminent. So this is all in nutshell for a baby with respiratory distress syndrome. See you in the next video with the next complication of preterm babies.